My name is Samira Daswani, the host of the podcast, The Patient from Hell. I have a very cool guest with us today. I have Cara Bohon, who is going to be talking to us about a bunch of topics that are near and dear to my heart. And I do not get the opportunity to talk about these things. So thank you for enabling me to have these discussions.
Yeah, thanks for having me. Excited to be here.
Cara, maybe we just start with your experience. You have one of the most incredible backgrounds I have seen in someone. So maybe you can just talk to us about where you started, how did you end up where you are today, and we go from
Yeah,
there.
yeah, sounds good. So I'm a clinical psychologist and a researcher who spent 15 years of my career in academia in academic medicine, and really was drawn to the field because of personal experience from a loved one having an illness that I was struck by and wanted to learn more and figure out how we could make it better and solve problems. And in that case, for me, my career started off in the eating disorder space for that reason. And so I dove in and started doing research alongside learning how to treat illnesses like eating disorders, and really spent a long time in academia figuring out what treatments worked for mental health conditions and feeling really frustrated that so many people didn't have access. And so I was faculty at Stanford in the psychiatry department for about a decade, where we had a clinic and I saw patients in our outpatient clinic. We had such a long wait list that we were turning people away and having to refer people out to the community. Then I'd get phone calls and say, "Hey, I called everybody on the referral list. They're full. I don't know where to go. Where else can I go?" And it felt just so frustrating to know that we had tools that worked and not being able to use them, and not being able to use them to help the number of people who needed it. And so about almost 5 years ago, I started thinking about different ways that we could better reach people and make sure that the things we were doing in academic medicine could get out to the people who needed them. And so I started just learning a little bit about business models and ways that people are able to access treatment if no matter where they live or where they are. And it propelled me into my departure from academic medicine into an industry space. And so I joined a company called Equip Health that really focused on bridging that gap between the demand and the need for treatment that works for eating disorders and the number of people who knew how to treat it. And so in that case, really, eating disorders are a good example of something where people go and they get trained in how to treat, to do therapy, to treat mental health concerns. And everybody learns how to treat depression. Everybody learns how to treat anxiety, but eating disorders is considered a specialty. And it's not something that everyone learns. And so that really creates this gap of people who know how to treat it versus the people who actually need the treatment. And what we did in the company that I joined was really think about how could we bridge that gap? How could we create the experts that don't exist in order to have enough experts out there, have enough people who know how to treat it in order to fill the demand. And so that's kind of how I went from, academics into, more of an industry kind of setting. And then more recently, I've been diving into the world of oncology and the needs of cancer patients. And so that's, how you and I first met and came together as I started thinking about the same thing going on for a lot of mental health and behavioral health challenges that cancer patients face. Again, it was personal experience and loved ones going through the illness that really pushed me into that area. But just thinking about the numerous ways that emotional well-being and emotional and mental health are impacted by a cancer diagnosis. And then throughout the cancer journey, the treatment journey, just thinking about the ways that numerous factors that play into someone's emotional well-being. and just thinking about the fact that it is also a situation where the mental health of cancer patients is another specialty that doesn't get trained, that people don't learn about. And so, yeah, that's where I'm at now.
I'm so glad you left off right there. Because that was going to be my very first question to you. What makes the mental health in the cancer patient population different than regular? I don't know what
Yeah.
you call it, mainstream. That's a
Yeah,
very
I'll give an example. One of the main treatments that is out there for depression, for example, is cognitive behavioral therapy. There's a lot of variations of cognitive behavioral therapy. We'll talk more about one of them later. But the idea behind cognitive behavioral therapy is you have thoughts in your mind and they pop up, and sometimes they are rational and make sense, and sometimes they are irrational and don't make sense, but they absolutely can impact how you feel about yourself or feel about a situation. And there's behaviors, and behaviors can also affect how you feel about yourself. So in the context of depression, when we're doing CBT or cognitive behavioral therapy, we end up looking at ways we can restructure thoughts, for example. And so, like, if you're sitting there thinking, oh my gosh, nobody's calling me to hang out, I bet nobody likes me. And that's a thought that goes through your mind. It makes you feel bad about yourself. And you can restructure that thought by saying, well, hold on. The fact is that people aren't calling you or wanting to hang out with you, but how do you know it's because they don't want to hang out with you, right? Do you have evidence for that fact? And if you don't have evidence for that fact, what are other things, other explanations for that, right? Could it be that they're busy and they're doing other things and it has nothing to do with you? Or maybe, like, gosh, what if your phone is broken and you're not getting calls because your phone's broke, right? It could have nothing to do with you, right? And so part of it is like restructuring where the evidence is, where the facts are, and being able to change that so that you change how you're feeling about yourself. Now, switch in and have in the presence of cancer, where the thoughts that go through your mind are, oh my gosh, this treatment is really painful. I'm having a lot of pain. Oh my gosh, I'm really worried about cancer recurrence. Oh my gosh, I'm so scared of how my loved ones are going to react to my diagnosis. Just flat out, I'm scared of, because I just got this diagnosis. It's really tricky to restructure those thoughts when a lot of those things are just true. It just is the fact, and you can't like say, oh,
yeah.
it's just change how you're thinking about it, right? Like,
Mm-hmm.
if you only thought differently about it, then your cancer diagnosis would feel fine, right? Like, it's not that simple. And so because of that, a lot of therapists actually kind of get scared of it because they're like, well, I can't restructure that thought because the thought is real and it's not irrational. It's the truth. And so when people are working in the space of, I'll even say the health of space of health, the space of health psychology broadly, not even just cancer specifically, but health psychology as a whole is a specialty where you end up getting training on the reality of the situation and how do you help people then move maybe toward acceptance and, okay, here is the reality and it does suck. And how am I going to be able to move forward in a way that is like aligned with my values, in a way that gives myself meaning, is a way that gives, hope to whatever the situation is, whether, because even in whatever time frame, let's say it's a terminal diagnosis, there's still something within that space for which you can have hope, but you have to be able to define it. And as long as so getting the training to be able to do those and have those conversations in the context of cancer or another serious illness is something that takes a little bit extra than your usual training.
I guess I have two questions. So it sounds like the training or education exists, and the gap in the market, for lack of a better word, is that, and I know you and I have spoken about this a few times because I think there are two gaps. One is there aren't that many mental health providers to begin with.
Yeah.
just with like depression, anxiety, kind of the more mainstream mental health disorders. And then we're talking about a population where 2 million new diagnoses a year, 18 million survivors. It's not a small sliver of the population, but it's not the largest sliver of the population. So then for a market environment where you have a shortage of providers and you have this training that's available, but not really easily done, how do you start to meet that demand?
Yeah, I think currently the best training that we have for it lives in academic medicine centers. So in hospital settings where they have training environments and also have strong cancer centers. So I'm Bay Area I'm in the Bay Area, right? So your Stanford, your UCSF, like there's strong cancer centers. There's also psycho-oncology, clinics that have training associated with them. But if you are getting training at a smaller place, at a place that doesn't have one of those strong centers, then it's absolutely a lot harder. And then to your point about just the availability of mental health practitioners to begin with being small, I think that's where we have to figure out how do we first of all get the training out of the medical center, and more accessible. So that's one of the things that we did at Equip with our eating disorder treatment, was to say, okay, we had kind of a similar setup where most of the time, if you were getting that specialty training, you were going to an academic medical center to get it. And we said, let's pull it out of that setting and let's just invest in it internally in our own company, so that when we hire folks, we are hiring them and we can say, hey, come in with the basics of your degree, your license, et cetera, and then we will train you on the specialty piece. And I think the same thing could be said or could be true for in a psycho-oncology setting as well, in the idea that like let's just pull everything we know about how to help this population, but pull it out of the academic centers.
Interesting. Very interesting. Huh. Okay. I have so many questions. I'm trying to hold myself back from going on the rabbit hole of business of healthcare. So, all right. What have you seen change in the last 20 years in mental health broadly?
I mean, the biggest change really was in the past 5 years, telehealth. You went from 100% of mental health being really brick and mortar settings of going to a clinic and having a session with someone, to the rise of telehealth. I think from a cancer patient perspective, that can be hugely beneficial too, if you think about just how busy patients are with all of the appointments that they've got going on, to add yet another location and visit, on top of that. The telehealth, the advent of telehealth, the expansion of telehealth has been really, I think, huge there. The other big one that comes to mind is especially if we're going back 20 years, really is this strong emphasis on evidence-based treatments. And so, back 20 years ago, if you said you were getting therapy, it was often just, let's just talk about your feelings, kind of like open-ended, supportive psychotherapy stuff. And really, in the last 20, I mean, probably maybe a little bit more than 20, but in the past 20 years, it's risen to the top, I think, in terms of this emphasis on making sure that the content of what you're spending your time on is actually like effective, that it actually does something.
Fascinating. I'm surprised to hear you not talk about all of the many ketamine.
Oh, well, that's even the most that's even like the last 2 years, really, or 2 or 3 years, it feels like, is like psychedelics and all of that. I think I think if I were going to make a prediction of the next 5 years, that's absolutely where I would put my money. If I'm thinking about growth, I think at this point, the psychedelic use is still so nascent that it just hasn't hit its time yet. But I do think it's coming.
Okay, super helpful. All right. So now before we have to transition to the paper.
Okay.
Maybe otherwise you and I will go down the rabbit hole. Maybe could you just summarize the paper for us, and then I have a set of questions.
Yeah. So this is a paper that came out a few years ago in 2019, and it's a clinical trial where they randomly assigned patients, cancer patients to, let me back up, cancer patients who were experiencing insomnia, and assigning them to either get 8 weeks of acupuncture, specifically targeting different, acupuncture points on the body that were known to be impact sleep, and then compared that to treatment that people were randomly assigned to that was CBT-I, or cognitive behavioral therapy for insomnia. And so similar to kind of what I was talking about, cognitive behavioral therapy in general is this, kind of approach where you're looking at thoughts and you're looking at behaviors that relate to whatever it is you're trying to change, and targeting those aspects of someone in order to change the end result, which in this case is the insomnia or the sleep. And so they randomly assigned 160 total patients, 80 to each condition, had them go through these treatments for about 8 weeks, and then measured a number of things over time, over 20 total weeks, looking at insomnia severity, a number of sleep quality metrics, pain, fatigue, depression, and anxiety, and then looked over time. A couple of just detailed things that I thought were noteworthy was also, all of the patients in the study started off with insomnia at a certain severity level, but they also had to be 1 month post acute treatment. So we're talking 1 month, at least 1 month post surgery, 1 month post chemo, 1 month post radiation. So none of the patients in the depth of the trial were currently undergoing any of those treatments. It stood out to me just because I often think of some of the sleep challenges as being sort of like chemo related or, treatment related. And so that's one thing that stood out to me, because it was like, okay, these are a month post. So these are kind of sustained sleep problems.
Got it. Can we just define insomnia?
Yeah, good point. So insomnia has a clinical definition in terms of thinking about difficulty both falling asleep and staying asleep. And so some people, when they are experiencing insomnia, they are having prolonged time that it takes to fall asleep. And we're not talking like, I tossed and turned for 15, 20 minutes. We're talking like, it takes me an hour plus or something like that to actually be able to fall asleep, or multiple wakings that you can't stay asleep for very long during the night. And then there's folks who unfortunately sometimes have both, the delayed, sleep onset, or the, difficulty with sleep onset, and the multiple wakings during the night. But all in all, insomnia is resulting in a lack of quality sleep, and ends up resulting in all sorts of challenges the next day. It also becomes a little bit like a vicious cycle of sorts, in that like you have a crummy night's sleep one night, and then the next day you're tired, you end up napping in the middle of the afternoon, or drinking a whole bunch of caffeine. And then lo and behold, the next night, because you napped and because you had a whole bunch of caffeine, now you can't fall asleep again. And then you can't fall asleep again, you toss, you turn, etc. You have a poor night's sleep, and then the next day happens again. You nap, you take a whole bunch of caffeine, you have, and etc. And kind of like keeps itself going.
Okay. Why is insomnia a problem with cancer patients?
Really, it's a problem for anybody, but if we think about, you're already experiencing, there's already a lot of pain, there's already a lot of fatigue, there's already a lot of, cancer-related cognitive impairment, we know is a thing too. And yet here we know that also, if you are sleep deprived, cognitive impairment is common, and it's a problem. It's really hard to focus and think if you are sleep deprived. Emotion regulation is incredibly impacted by sleep. If you don't have adequate sleep, it's really easy to just like get set off by little things, get irritable, and that can impact your relationships with your loved ones. It can impact your, ability to function at work or at school. The cognitive impairments, you can end up being forgetful, and you forget to take your meds, and you forget to do a number of things that you were supposed to do because you're sleep deprived. And so while all of those things are true for anyone with insomnia, the impacts of someone who is already dealing with pain, fatigue, emotional distress, etc., is just kind of compounded.
Got it. Okay, so I have so many questions. Maybe we should go into the intervention land.
Yeah.
So there's insomnia, and then the paper studying CBT versus acupuncture.
Yeah.
Could you maybe talk a bit about acupuncture and then
Yeah.
why
So
would we compare those two things?
yeah, so the authors of the study they really designed this thinking about access to treatments as well. So CBTI has a lot of research and evidence backing it up to support its use for treating insomnia, and yet data show that maybe 15% of oncologists would be referring someone to get CBTI, even though we know that it's an established treatment.
Huh.
Whereas acupuncture was actually readily available and referred often in some of the data. And so now some of that in this is me projecting and making conjecture. No idea if this is true, but I imagine that part of the reason that acupuncture is much more readily referred is because there is a lot of evidence on acupuncture's use for pain and fatigue and things like that. And so if you think about the whole package, you're like, oh,
Yeah.
well, if I can kind of hit a bunch of birds with one stone, let's send them to acupuncture. We can hit sleep. There are points, points for acupuncture to put the needles in the body that target sleep. There's additional points that you can place the needles to target anxiety. There's additional points that you can target for pain, etc. And so it's like, all right, let's just like one-stop shopping. Let's go. We can place the right ones for the right indications, and then they've had one appointment and they're good. And so it makes sense from the oncologist perspective. Like, okay, let's just send everybody to acupuncture because they can pick all these points, as opposed to having like, okay, well, for insomnia you're going to do this, and then I've got to do something else for this, etc.
Hmm.
That's the part that's my conjecture about what's happening, but it seems like it would make sense, right? Like, why would you more readily refer for acupuncture?
Fascinating. So this is I actually never thought of it that way. I never thought of it that way. Can you
I mean, maybe I'm wrong. There might be another explanation, but
the only reason you see me sort of like be like I've not thought about it, I was in a PPO plan. So
uh-huh.
my oncologist never really put in referrals for either mental health or for acupuncture. That was all sort of self directed, which is
Yeah,
the only reason you see me be like, but that's just because I didn't go through. Doesn't mean it's not true. It's just
yeah, yeah.
yeah.
Well, I mean, that this is you'll get me on a different kind of soapbox then, which is like, oh, I want like integrated care so much. I really want us to have like, you get your oncology, your oncologist gives you your cancer diagnosis, and then boom, here's your here's your behavioral health like specialist to help you think through what next and what else might be available to help you in a billion different ways that you might be affected. Like that's my dream situation, is like to have that just be hand in hand, so that you're not sitting there saying, let me figure out who exactly my insurance covers for X, Y, and Z things that I think that I have, and then go hunt it all down, right? I mean, you know this well.
Yes.
Yeah.
Yes. Okay.
Um, yeah.
So why compare those two things? So why compare CBTI versus acupuncture?
Yeah, so in any clinical trial, you want to have some kind of a comparison, right? So you could study one intervention, but then you wouldn't know if that singular intervention is just regression to the mean, meaning everybody kind of initially has something and then things just get better over time, or maybe things just spontaneously resolve on their own and it has nothing to do with what you do. I say this sometimes, which is like, what if you just like licked a shoe once a day, and with that, like, well, no, that of course that's gross and it wouldn't make any sense, but like the point being like, there's like something, I know, why is it licking a shoe? It's just the thing that comes out of my mouth, I don't know. But the idea being like, you could do anything and something might change, but like so you have to have some kind of a comparison, right? And the idea here is like, okay, it sounds like the authors really were interested in CBT for insomnia in cancer patients specifically, because there wasn't really a lot of data in cancer patients in particular. And when you think about like whether or not insomnia is a byproduct of cancer treatment or, certain medications or things like that, you'd want to say like, all right, let's make sure that it's actually helpful and working in this particular population. And we have to have something to compare it to. And so let's pick something that we think a lot of patients actually do have access to, because it seems like a fair number of oncologists are familiar with acupuncture as a referral.
Mm.
And two, there is evidence for acupuncture as a sleep treatment. And so it seemed like they're like, all right, well, this is a fair comparison where there would be something, and it would be meaningful in the sense that if their results showed that acupuncture actually is either just as helpful or even more helpful, then hey, great, we've got something that's accessible.
And what did the study find?
So at 8 weeks, which was like the point where the intervention ended, and it was they basically had their two primary time points was 8 weeks and 20 weeks. 8 weeks was at the end of the intervention, and then 20 weeks was sort of the like follow up to see like how long did the effects last after your acute phase of treatment. So at 8 weeks, already at 8 weeks, the CBT-I group was doing better in their insomnia in terms of like the severity reduction. So already by the end of this 8 week intervention, the group getting CBT had better sleep. And so the insomnia severity was better. And then they looked at this over time, to this 20-week follow-up, and CBT continued to outperform the acupuncture group for that time frame. And so when you look at and all of the sleep related measures, so insomnia severity and sleep quality, so they can look at various aspects of the sleep, and all of those things looked better in CBT. They also looked at, which this is what I found interesting, pain, anxiety, depression, and sort of some other global health things as a secondary factor. And knowing what I know about sleep impacting those things, we know that sleep exacerbates anxiety, lack of sleep exacerbates depression. Like one would think that, okay, if there's an impact on sleep, then maybe there's also going to be an impact on these other things. There actually wasn't. So acupuncture and CBT did similarly in terms of pain, any changes in pain, any changes in anxiety, changes in depression, with one exception. At 8 weeks, acupuncture actually did a little bit better than CBT for pain specifically. But if you remember, there's actually some pain points for acupuncture where it's like a direct target. And I'll add, which kind of maybe supports the idea that it's related to the acupuncture specifically on the pain points, is by 20 weeks, when they had stopped the interventions, there were no differences in pain between the two groups.
Very interesting. So if I'm a patient listening to this, my conclusion is do both.
I mean, maybe depending on what you're challenged with. Yeah. Because if you want to get that acute, I mean, I will say the fact that the pain benefit of acupuncture didn't persist suggests to me, at least, that it's a more acute effect. Like it's something that like when you're doing the acupuncture, you get that benefit from, but when you stop the acupuncture, you also stop getting the benefits. And so to the extent that you can continue the acupuncture for pain, then maybe there's something there. But if you're looking for something that I'm going to do and then stop and still want to see the effects, then it's not going to matter.
Got it. Okay, super helpful. So now maybe zooming back out into access and the kind of systemic barriers that exist today in the world of like psycho-oncology plus minus acupuncture. In your wildest dreams, how do you solve it?
Yeah, I think. Okay, here's my dream. My dream is, my real dream is every patient at diagnosis has access to a behavioral health specialist who can walk them through and get them to the right place where they need to go. So that, again, you're not having to do your own research and hunt things down, right? But you have someone who is able to sit and talk with you about what are your needs, what are your challenges, and where, and and start to direct you so that they would be able to say, hey, I hear that you're really struggling with sleep right now. And we know that CBT for insomnia can be really helpful for you. Let me help you find someone,
Yeah.
and would be able to like walk you through that so that you're not having to navigate that yourself. And then, but then there's the access piece of, where do you find the person for who does CBT for insomnia and also understands the impact of your
Yes.
medications or your pain and fatigue and all that kind of stuff, that layer of the cancer that is on top of that. And I think that's where, again, back to, we need more training and we need more people trained,
Yeah.
is a big factor there.
Okay. Any other question I should be asking you about the paper that I'm not asking you?
I mean, I'd love to just give a little bit of a run through of what CBT for insomnia looks like.
Oh, let's
So
do it. Yes,
yeah,
I'm ready.
um, since it was the one that outperformed. Also, I can't tell you where on the body they did the acupuncture ones anyway, so it wouldn't be helpful to get details on that one. But I can walk you through CBT for insomnia, which, first and foremost, one of the things, it's kind of weird. They call it sleep restriction. And it's so weird to me, right, to say, hey, we're going to treat your sleep with sleep restriction. But it goes back to what I was talking about, that vicious cycle that starts to happen, where because you are taking naps and because you are drinking caffeine and doing all those things, you end up making it worse for yourself. So that basically it's like, I don't know if you've traveled internationally and you have, a big time zone change and you're like, I just have to push through and keep myself awake until I can get back on this new time zone schedule. It's just like that. It's basically push yourself through and do not nap and do not fall asleep and do not take, everything. Push yourself through any tiredness that you have so that you can actually fall asleep at the right time as opposed to taking a nap earlier. So
Wow.
that's the sleep restriction part, right?
Fascinating.
So that's where they start is, first of all, restrict your sleep during the day. It's going to be tough to sleep at night if you're sleeping during the day. So restrict that. Then
Yeah.
they do what they call like stimulus control. And what that basically means is you have a stimulus. We're all kind of stimulus response creatures, right? So like, here's a thing, like, smell something really tasty and you go want to eat it, right? It's just like you respond to your surroundings. And one thing that happens to us is that we respond to our environment at night in the sense of a dark room in a bed with blankets, cozy up, is a stimulus that stimulates us to sleep. And if we have reassociated that stimulus of the dark room and the cozy bed with awake, then we're going to basically we're recoupling that process in our brain to no longer to have like disrupted what we should couple together is sleepy time is dark room in our bed with now awake time is dark room in our bed. And so we want to make sure that we are not making that mistake by, if you are awake for too long, get out of bed.
Fascinating.
So just because you want to disrupt that association. And so the stimulus control is making sure that anything that you want to stimulate bedtime stays pure with sleep. And if it's not, if you're awake, then make sure it's very much not related to a bedtime behavior. And you can also then create new bedtime behaviors or additional bedtime behaviors to say, okay, this is how I want to train my brain to, respond to these stimuli to say it's bedtime, I'm going to sleep. So that's the stimulus. So, and those I would say are the two biggest like components of CBT-I, is this sleep restriction and the like stimulus control thing. And then they layer on like other things of like, there is cognitive restructuring, which we talked about earlier around like changing your thoughts. And so if you're sitting there and part of your difficulty falling asleep is like anxious thoughts going through your head, it isn't necessarily even restructuring, but maybe like, so for example, if you can't fall asleep because you have a scan tomorrow and you're worried about, what the scan might show, whatever, and those are the thoughts that are going through your head, and because those thoughts are going through your head, you can't sleep, then the cognitive restructuring is not denying the fact that that is a real fear and that makes sense, but just saying like what I often do is like, how helpful is it to have this thought right now? Like, is it helping you? Is it going to make any difference with what shows up in the scans tomorrow? Is having this thought going to help the scans be better tomorrow? No, it's not going to. Okay, so you start to kind of talk to yourself around those thoughts to try to diminish the loudness of them, so to speak. And then they also do relaxation, which is just the physiological arousal that might be going on. So if your heart is racing, if you're tense, if you're feeling, just that physiological arousal that makes it hard to fall asleep, it's just literal just relaxation techniques, which could be some deep breathing. It could be some muscle relaxation. It could be, a number of different like imagery sorts of settings. Imagine yourself on the beach. A number of different relaxation techniques to get your physiological, arousal down. And then kind of coupling all of that stuff together. So the sleep restriction, the stimulus control, the cognitive restructuring, and then the relaxation, all of those things hitting the possible drivers of your insomnia. So that's the gist. That's what CBT for insomnia looks like.
That's actually super, super helpful. That is really, really helpful. I'm super glad you just said that, because I think you just give patients a step-by-step guide.
There you go. You don't need to get a therapist. Just
exactly.
go for it.
Exactly. Yeah. You can't find one, you can't afford one, and you have insomnia. That was amazing.
There you go.
I need to transition us into rapid fire.
Yep.
Ready?
I'm ready.
Short questions. I think I have 4. So the very first one is, what advice do you give to a newly diagnosed cancer patient?
Ask for anything that you need. Just ask. Don't be afraid to ask. Because I think there's just so many times when, when you're worried, you have so many thoughts going through your mind and you can't get any of them out, but just like ask for help.
What advice would you give to someone caring for a cancer patient?
Find someone to confide in that is not your loved one with cancer, so that you can feel free to, vent about how hard it is without feeling bad. There's again, so many times when I think cancer is hard on loved ones, and yet they feel like there's no way I could tell my loved one that, because they already feel bad. I don't want them to feel bad for this. So finding someone else that you can kind of confide in and vent to sometimes, just because it's hard.
Okay, if you can't afford mental health, therapy, psychotherapy, CBT, acupuncture, if you can't afford it, what is your go-to for free resources?
Interestingly, the VA has a number of evidence-based apps that are really good, including one for CBT-I for insomnia. The VA developed these, and I think the CBT-I one, maybe all of them, I'm not sure. It's part of the National Center for PTSD, but so it was built, I think, with the idea of helping veterans with PTSD who have insomnia, but it's a generalized app. It's not, the app doesn't have anything to do with PTSD. It has to do with insomnia, and it's great. And they have a number of other apps. It's not just CBT-I is one of them, but they have a few apps. And even though they're made for the VA, they are open to the public.
Oh wow, good to know. Okay, we will link to that in our show notes.
Yeah. Huh. Yeah.
Okay, my last question for you. There is this beautiful image, I think, of a Hindu god behind you. Is that right?
It is actually
or an elephant.
Yes. And it is a poster from a concert that I went to at the Fillmore in San Francisco. And if you've never been to a concert at the Fillmore, if it's a sold out show, they have free posters that they give to everyone at the show. And so I went to this concert in 2013, the date's on it. And that's what it's from.
Oh my God. What was the artist? Who was the artist?
It's the Walkmen and Father John Misty played a show together. And and I have no idea why that is the image on it, but I just thought it was beautiful. And so I framed it put them out.
Oh, that's amazing. Okay. All right. That was not what I was expecting. That was great. Well, thank you so much, Cara. This has been such a wonderful episode. I am very excited for people to get access to this because I think people will take away some very, very important tips and tricks. And if you're going through cancer and dealing with insomnia, you just gave us at least a mini playbook. So thank you.
Awesome. Thanks for inviting me. It's been fun.
This episode was supported by an award from the Patient Centered Outcomes Research Institute. This podcast, show notes, and newsletter is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice, and no doctor-patient relationship is formed. The use of information on this podcast or any materials linked from this blog is at the user's own risk. The opinions of the speakers are their own and do not represent the opinions of organizations they're affiliated with, nor do they reflect the opinions of Manta Cares Inc. or Manta Cares' sponsors.